Thank you for joining us in our first ever online Q&A session on the subject of CMT, Charcot-Marie tooth. It's a hereditary medical condition that damages the peripheral nerves, which means that muscles become progressively weaker over time. This month, October, is our awareness month, so I'm hoping that this video will reach out to people and they can understand more about CMT, what it is, generate more awareness around the condition and around our charity, CMT UK. My name is Simon Bull. I'm Chief Executive of CMT UK, which is the UK's only charity dedicated to supporting people affected by Charcot-Marie tooth disease. And I'm joined this afternoon by Professor Mary Reilly, who is one of the leading UK authorities on CMT and is Professor of Neurology at UCL Queen Square, the Institute of Neurology. And we're also very lucky that Professor Reilly is the patron of CMT UK. Mary will be answering some of the questions that you have sent in and have been sent in by the CMT community. So welcome, Mary.
Thank you very much, Simon. I'm very pleased to be here.
Thank you. So I have a number of questions that people have sent in. But first of all, I thought I would start by asking you, what is CMT and who does it affect?
So I think that's a very relevant question because I'm sure many patients who are diagnosed with CMT, when they look up the traditional literature or online, it doesn't quite fit what they have. So as you said, it's called Charcot-Marie tooth disease to reflect the names of the three men that described it in 1886. But it also refers to hereditary motor and sensory neuropathy. So it's a disease that affects the nerves for movement and the nerves for feeling. So the nerves for movement mean, as you say, that the muscles affected waste, that is, become thinner and become weak. And the nerves for feeling means when you touch the skin, you don't feel things as well. Now, it usually affects the longest nerves first, that is the nerves to the feet, because the nerves to your feet are about 1 meter long, and then it affects the hands, but it can affect other parts. Traditionally, Charcot-Marie tooth disease, in the purest sense, refers to having both motor and sensory involvement, and therefore it's also called hereditary motor and sensory neuropathy. But in recent years, we use the term more generally to cover CMT, but also hereditary motor neuropathy, which is the pure motor form with normal sensation, and hereditary sensory neuropathy, which is much more sensory involvement, and also hereditary neuropathy with liability to pressure palsy, where patients tend to get palsies in an individual nerve. So when people talk about CMT now, they mean that family of inherited diseases. And the reason for that is the genetic causes often overlap between them. So that's what it is. Who it can affect? Well, the answer is very simply anyone. So it's not restricted to males, females, children, adults, or any ethnic group. It's been described in every ethnic group around the world. And there are many different causes. There are now about 120 genes, and they can affect anyone from very young children to people getting it in their 70s and 80s. So it can really affect anyone depending on the type.
Thank you. And what research is there currently being undertaken into it?
Well, there's many different areas of research, and there's a very active research community worldwide. And there is this thing called the International Peripheral Nerve Society, which is a big international medical community that we're all a part of. And within that, there's now a CMT and related disorders group. So it connects us all internationally. So I think you can divide the research into various areas. Firstly, there will always be research directed at finding the causative gene in individual patients. So until we know the cause of CMT in every single patient, that research will continue. So to date, on average, in my practice and in a similar practice in the States, so they're two fairly, you would say, specialized clinics that have both research and clinical, we would diagnose about 73% of patients. We'd get an accurate diagnosis. So that still leaves about 27% of patients without a genetic diagnosis. And that affects much more what's called CMT2, the type that affects the axon, that is the center of the nerve, rather than CMT1 that affects the myelin. So that's a huge area of research. The second area is, once genes are found, is to find out how an abnormal gene causes the disease. because that is how you learn to treat the disease. Thirdly, once that's done, there's a huge amount of research, and I'm particularly involved in this, in working out how we do clinical trials, because patients will often appreciate that it's difficult to see changes over months, but easy to see changes over years. So we have to develop surrogate markers, that's markers of the disease that we can tell it's progressing, even if the patient hasn't noticed any progression. And when we've developed those, we can then do clinical trials. And then there are the clinical trials. So there's a huge amount of work going on developing drugs, therapies, and gene therapies to bring to clinical trials. There are some clinical trials ongoing currently, but the biggest revolution in therapies, that is the genetic therapies, are in what we call the preclinical phase. So the trials at the moment are involved in models in the laboratories rather than in actual patients themselves. And I point out to patients with CMT, there is a reason it always feels like it's slower in development than other diseases. There is another disease I treat, another hereditary neuropathy called TTR amyloidosis, where we have gene therapy that we're using since July 2019 licensed. But those diseases are more serious diseases in that they affect the lifespan of the patient. Or if you think of spinal muscle atrophy, when babies are born, they may die in the first year of life. So when therapies are developed, you're allowed to do clinical trials very early because there's very little risk if somebody has a very severe outcome in any case. But most people with CMT have a normal lifespan. And therefore, if you deliver therapies to patients and develop therapies, they have to be really safe. You absolutely cannot do more harm than good. So that area is very much under development at the moment. And there's a big group of people worldwide looking at how we get gene therapies into the nerves, but they don't affect the rest of the tissues and cause side effects. So that's the way I would divide the groupings of the research that's ongoing currently.
Thank you. Is there currently a cure for CMT or any treatments?
So if you talk about a cure, there is no cure. There is no drug or therapy at the moment that can reverse the disease or prevent it progressing at the moment. In terms of therapy, so if you ask about a pharmacological therapy, that is a drug therapy or gene therapy, there is none that has been developed to the extent where it's licensed for CMT at the moment. But there are many therapies to manage the condition. They include physiotherapies, occupational therapies, pain management. I think the whole area of surgery is a massive area, and that's another big area of research that's needed. When do you get the surgery for your foot? What is the right surgery for your foot? Who should do it? What age should it be done at? That's a huge area. So there are therapies available, but it's quite difficult with surgery sometimes to do a trial. So a surgeon, in a way, is trained a bit like an apprentice. So you train with a particular person and you become really good at their way of doing things. So you can't ask that surgeon to do a different operation every second patient to see which one is best, because they'll be expert in a particular way of doing things. So we have to find international ways of comparing outcomes to work out what's the best. So there are therapies, but none curative as of now.
Thank you. Yes. And as we often get asked in the CMT UK office about links between CMT and muscular dystrophy.
So that's an interesting question. It's a historical problem because, and it's all to do with nomenclature. That is what people call things. So years and years ago, that is only the last century, we didn't have neurophysiology. So when people had wasting of the muscles, we didn't know whether that was due to a muscle problem like muscular dystrophy or to a nerve problem like CMT. So they used to be called, I have patients whose relatives, particularly during the Second World War, were called having a muscular dystrophy. But we now know they are very separate conditions. CMT affects the nerves to the muscles. Muscular dystrophy affects the muscles themselves. So they're different conditions with different causes, but they both affect the way we move. So there are common symptoms as well.
Thank you. Another question we get asked is about B12 deficiencies and the link between CMT.
Sure. So there's no actual link between B12 deficiency and CMT. B12 deficiency does not cause CMT, but I tend to do a B12 test on my CMT patients when I see them first, because it's a bit like doing an MOT. So we know there are certain things very important for your nerves, and one of them is having enough B12. So if you become deficient in B12, people can get a neuropathy. This is independent from CMT. So we always think that if you have CMT, you don't want a second problem. And in the UK, the commonest cause of B12 deficiency is people that used to be meat eaters and then become vegetarians. So people that grew up vegetarians or vegans tend to be better with managing with less B12. But I have found in my practice, people that give up B12 and then maybe are not as experienced at having the right diet otherwise. So you have to be careful about B12, but it doesn't cause it. It's not linked to it, but it's just you don't want a second cause of a neuropathy when you have CMT.
Okay, thank you. Yes. As a new vegan, I better watch my B12 well.
Absolutely, yeah. Absolutely say that.
Moving on to some questions we've had via through our members. I should read this one out. Our 11-year-old child has CMT1B as a spontaneous mutation. He was diagnosed at age 3. He's managing well, but stopped receiving external physio sessions due to some reorganization within the trust. He only receives the 6 monthly checkups with his neurologist. I am concerned he might develop sclerosis without us noticing it in time. Is this common in children with CMT, and does CMT speed up the progression of scoliosis?
Okay, so I think that's a very good question. So first of all, de novo mutation, for those that don't know, means neither parent carried the mutation, but it happened for the first time in the child. And everything we have that's inherited, even if we got it from our father or mother, somewhere back in our ancestry, it started. So we know with CMT about 20% of some forms of CMT are de novo. They start in an individual person. And that's hard to diagnose if nobody else in the family. So in terms of scoliosis, with all forms of CMT that start in childhood, so scoliosis is where your spine develops curvature problems. So it can only happen if you have a problem with the neuropathy during childhood. So if your neuropathy starts in your 20s and your 30s, you don't get a scoliosis. But the really dangerous time to a certain extent is the teenage years. So if you grow very fast, your spinal cord has to grow. And if you have a neuropathy, it can sometimes be more difficult. So scoliosis can occur, particularly in the early teenage years. But in terms of monitoring it for it, it is important. I mean, most people say 6 months would be enough to monitor it, to look at it, usually. But I would say to any parent, if there's any concerns in between times with the child's back, they just contact and get an earlier appointment. So I can't really comment on an individual case with therapy around the country, because it's such a minefield of differences in various parts of the country, accessing physio. And many of my patients say they get to go to a physio, they get 6 sessions, and then they never see them again. And that happens all the time. And of course, this year with COVID, nobody sees a physiotherapist except online. So I think it's been a difficult time. So I would say that 6 months is the standard, sometimes a year in the NHS. But if there's ever any concerns, do not be afraid to ask to be seen sooner. Absolutely. Some scoliosis needs surgery, some doesn't.
Okay. The next question. Our son wears splints, AFOs, at night time only. Are there any studies supporting evidence that this is beneficial?
That's a very good question. And first of all, I'm going to say that I'm an adult neurologist, so I see people generally over the age of 16. I do occasionally see children in Great Ormond Street for a second opinion, so I'm not an expert in pediatrics. But I know it is very common in children with many different diseases that affect muscles, including CMT, to do nighttime splints. And you know, the question, to my knowledge, there's never been a trial done to see does it help or not. Intellectually, you think it probably will help because you think it is doing a stretch at night. But to my knowledge, there's been no studies done to show that. I would say, though, that one of the major problems with the common form of CMT, that's CMT1A, that affects 60% of patients in the UK with CMT. So even though there's 120 genes, 60% of people have one particular problem. And the commonest problem is foot deformity. And by the time I see them at 16, 17, they have foot deformity, and they may or may not need surgery. So instinctively and intellectually, you feel if you pick up early enough that there's a potential problem and work hard on the muscles and the therapy, at least in some patients, you can keep the ankle supple and not need surgery. And I'm not saying that can happen in 100% because there's an imbalance in the muscles that are weak. So I think, you know, that is the rationale for night splints, is to try to give some balance to the muscle and help it. But to my knowledge, there hasn't been good trials looking at that in CMT. But a lot of what's done by therapists, they do it from experience rather than trials. We're trying to rectify that at the moment. But until the trials are there, I think it's, you know, if you're seeing a good therapist and they think it'll help, it seems to me sensible. We don't ever use night splints in adults. Remember as well, adults would actually, if they say no, the word is no. If your poor child says no to you, you can say yes anyhow. So adults wouldn't do night splints, I think.
Mm. So worth trying, because in some cases they...
So I think it depends on the child and the therapist. It's one of those things that I think has to be an individual question.
Okay, thank you. Is the progressive distortion of our limbs caused by CMT treated within the NHS by the departments for CMT? And can we improve the quality and speed of our help by getting our GP to refer us direct to an orthopaedic consultant?
Yes, I mean, I saw the example of the problem you sent in that. I mean, whoever sent this problem in, I have huge sympathy. So I think the problem is that throughout the country, the people that are best to see varies. So you can't give one answer to that. So certainly where I work in London, we have an adult practice here in Queen Square, and literally next door are the children's practice in Great Ormond Street. So we see the families together in, you know, two different buildings very close to each other. So clearly we feel you should see a neurologist first, and then we have very good orthopedic teams who are experienced in CMT. Now, in other parts of the country, it may not be that there is the availability of the neurologist, and it may actually be that there's an excellent orthopedic system that knows CMT or are very good at it. So to me, the important point is seeing the right person for your area. And I think that does vary throughout the country. Often the pediatricians, it can be many patients historically have gone through orthopedic surgeons before neurologists throughout the country, because there's not that many pediatric neurologists. Sometimes there'll be excellent pediatricians in the community or in rehabilitation who are very good at seeing them. And sometimes it'll be excellent orthopedic surgeons. So one of the things we've talked about, Simon, and we've done with CMT UK to a certain extent, but perhaps it's something that could be done again, is have a registry throughout the country of who sees CMT patients, adult neurologists, pediatric neurologists, and what surgeons do. There is a group in the UK called the ankle foot surgeons, and they're a group, and actually that group would be the group you'd want somebody. If I had a child that had CMT, I'd want the operation done by somebody that does CMT surgery a lot. You want someone that's seen them, because recently internationally we did a study which we've published, and we took the best CMT centers in the world, and we got the surgeons that operated for those centers. So these are people that do a huge amount of CMT surgery. And we, with Dishan Singh, who's an orthopedic surgeon expert in CMT in the Royal National Orthopedic Hospital, Stanmore, we put together a couple of cases for adults and pediatric surgeons saying, what would you do if you saw a child with this? And in all of the surgeons, only 2 surgeons agreed what they do in the whole world. And these were 2 pediatric surgeons. Now, it doesn't mean anyone was right and wrong, but everyone's approach was different. But the important thing is you see a surgeon that's used to seeing CMT so that they know the disease. And they may have their way of doing it, but that's the most important. And I think if there's huge delays, as there seems to have been in this case, that is tough on the child, and there shouldn't be. But in different parts of the country, the way to get around that does vary.
Right, so you wouldn't necessarily get referred to another area?
But sometimes it needs to be. I mean, ideally, people would see a pediatric neurologist first and then see an orthopedic surgeon shortly afterwards. But that is just not available in the time frame that children need. And I think if parents feel, they can always ask for an opinion out of area. Of course, that's really difficult right at the moment, because of COVID. But generally, that is possible. But most parents do like children to be operated on as near home as possible if there is good surgery, because to avoid the travel and the clinics, etc. So, but I think it is a really important question, and I think parents need to be enabled to have more information about what surgeon does what, etc. But it is available on the NHS. There is surgery available throughout the country, but there certainly are excellent centres. And I would have thought that it should be surgery. It should be a centre that does it routinely. It shouldn't be a centre that does one a year. You don't want someone doing CMT surgery that only sees one patient a year with CMT.
Okay. The next question is about somebody who was diagnosed with CMT in about 1991 following a family history of varying degrees of CMT, varying degrees of severity, that is. This person's had their blood screened for genetic markers at least twice, and they cannot identify the type of CMT. How common is this, and are there any implications for this person or for their children regarding treatment in the future, not having the information?
I think that's a really great question, because I think it really gets down to the crux of the matter. So in 91, we discovered the first gene for CMT. In 2020, we've about 120 genes. My group personally have discovered 3 or 4 genes in the last year. So 5 years ago, we're already 20, 30 genes new. So if you get screened today, you will only have what's been published up till about a year, 2 years ago. So all of the stuff we've published this year, that will not be available yet in diagnostic labs. So there is a lag time to develop it and to get it in. So I think it is always worth doing it. So as I said at the beginning, we know the cause in about 73%. So about almost 30% of people, we don't find the gene now, but every year we get better. Now, I have had the touching experience of having people in my clinic. I became a consultant in 1998, whom I saw in 1998, and I'm given the diagnosis now. So that's been 22 years. So some people, it's complex and difficult for us, and then some people it's not. So we now bank DNA on the research side. So if we have someone's DNA and we do the testing, we never get rid of it. So every time we find new genes, we go back and check. So I sometimes write to people I've seen them 10, 15 years ago, having now found the gene. So I think that's the first. But the very important part of that question is, would it make a difference? And I think it will. So people listening to this may find that when they've gone to the GP years ago, they said, well, there's not much point in seeing a specialist and having genetic testing because there's no treatment. So it's unquestionably there will be treatments for CMT. We now are at the stage where we have treatments for certain genetic conditions, and there will be treatments for CMT, but they will be gene specific. So the first step has to be to know what gene it is, because the treatments will not suit everyone. The treatments are being developed now for particular genes. So I think anybody with CMT deserves to get a diagnosis, because it will influence treatment, but it also influences what we do now. So with certain forms of CMT, if we know what type, we can give you a much more accurate prognosis of what will happen in the future. And there are certain kinds of CMT that have specific things to do with them. That means we will do different kind of testing to monitor things. So I think it is important we try to get a diagnosis for reasons, but it will be even more important in the future.
So somebody who's been tested 5 years or 10 years ago, should they ask for another check, another screen?
Yes,
or
they can ask for another screen, or they can get referred. I mean, it's ideal. I mean, we're not saying we can see everyone here and everyone doesn't want to come to London. That's not appropriate. But there are centres around the country, including ours, that do research and clinical practice. And we would look. And sometimes when someone lives miles away, their consultant and their GP would write to us and say, this is my patient. Do you think it's worth you seeing them? And I would make a judgment whether we can offer something extra. Or they would say, this is my patient, we have found this gene. They don't want to come to London, but can you put this patient on your database? So if there's a clinical trial, you know about them, and we do that as well. So I think there's all kinds of ways, particularly in the new virtual world, of us keeping in contact. But certainly, absolutely, somebody should ask, can they have another test? And the UK has actually, been very forward in developing whole genome sequencing. It is actually, the NHS has actually been a leader in making this available for everyone in clinic. So it's not available 100% of the time, but we are actually in a position through the NHS to be offered fairly comprehensive testing as routine practice now. Very comprehensive compared to many countries in the world. So I think, if you're in the US, for instance, yes, you can get very good testing, but it depends on what your insurance company will pay for. So we don't have all that headache in the UK. We're full of money in the UK, of course. Can't say that, can I? Because it's not true. But in the NHS, if it's standard practice, everybody's eligible. And that's one of the really nice things about the NHS, actually.
Indeed. The next question from a CMT member came in by email. My CMT has resulted in quite a severe impact on me. I am now in a wheelchair full time and have considerable strength and dexterity loss in my hands and arms, meaning that I require significant levels of personal care and associated support, resulting in me now living in a care home for the disabled. On the brighter side, I have no pain. In fact, a nurse once questioned my diagnosis because I had no pain associated with my symptoms. What proportion of people with CMT experience no pain, and why does the condition cause pain in some and not in others?
That's an excellent question about pain in CMT, because you're absolutely correct. It almost was the opposites. When I was a medical student and when we learned about CMT, we were told it doesn't have pain. That's one of the ways you tell CMT neuropathy from other neuropathies. Like, I don't know if people have diabetes, but diabetic neuropathy is always painful, almost always. So that's one of the big differences. So I would say that there's two different kinds of pain. So I don't think I've ever met a patient with CMT that doesn't have some pain. But there's two different kinds of pain. There's pain that's generated by the nerves. That's called neuropathic pain. And that is rare in many forms of CMT. You do get it, and it's very common in certain rare forms. It's actually so common in some rare forms that it tells us about the diagnosis. But in most people with CMT, they don't get neuropathic pain. That is pain generated by the nerve. But almost everyone gets pain from the complications of the musculoskeletal system. So I suspect if people are listening to this, there'll be practically nobody that hasn't had ankle pain, foot pain, shin pain, deep muscle pain, sometimes feeling like you've run a marathon when you've only done 100 yards, cramping type pain. And as you get older, if your body hasn't moved normally for your whole life, you do tend to get arthritic pain as well. So I think pain is common. Neuropathic pain is overall less common than other neuropathies, but in specific types of CMT, you do see neuropathic pain. Now, there's an incredibly rare form, which is called congenital insensitivity to pain, where there's this terribly rare form, one of the wider family of CMT, which is a sensory neuropathy where people are born without sensitivity to pain. And that's actually very dangerous. If you have no pain as a baby, you bite your tongue when your teeth are developing, or you will have injuries, multiple fractures, and never feel them. So actually, that's a very rare form, but it is there as well. But as I say, almost everyone, I don't think I've ever met a patient that hasn't pain. And I've met some very angry patients who've said, I've been told you can't have pain, and I have pain. So I would never say to a patient, you can't have pain.
Okay. This question came in from, it's coming through Facebook. My daughter is 16 years old and has CMT4J. She was diagnosed at the age of 10. And I remember speaking to a consultant about when it comes to her starting a family. We're not anywhere near that yet, thank goodness. But something that stuck in my head was that when and if she decided to start a family, and if she was to have a boy, there's a possibility of it having horns. I can't remember much more about the conversation other than breaking down in tears.
So I read that question, and I have to say that completely threw me. It's very rarely I'm asked something that I've never been asked before, but I've never been asked this. So I don't know who told you what, or whether they mispronounced something, but horns, which is a bony abnormality, you just don't get horns as part of a neuropathy. So that answer is absolutely not any kind of horns that I can think of. No connection at all.
Lovely, thank you. Put that one to bed. The next question. My partner suffers from inherited sensory neuropathy, CMT. He has spent years taking pregabalin, then gabapentin, then swapping back again, and he's still in lots of pain, despite also using cocodamol, lidocaine plasters, and ibuprofen gel. What are your opinions on the use of cannabis for treating pain? And is there any current research going on into the possibility of the effect of cannabis in the treatment of CMT?
Okay, so first of all, that fits very well with the question I've just been asked, because there's a rare form of hereditary sensory neuropathy where neuropathic pain is very, very common. It's hereditary sensory neuropathy type 1 due to a particular 2 genes. And the neuropathic pain can be very severe in that form. And the type of drugs you're describing are the ones that are used. So people tend to use drugs that were originally developed for epilepsy, like pregabalin and gabapentin, or drugs like lidocaine plasters, which are local anesthetic plasters. So you mentioned many of the different drugs that are used. And this neuropathic pain is as difficult to treat in this group of patients as it is in any other patient with bad neuropathic pain. So I have huge sympathy because I have a number of patients myself. Some we've managed to treat fairly successfully, but I'm bringing to mind a particular patient I can think of now that despite us trying really hard for 20 years, we haven't got on top of the pain. So it can be very difficult. Cannabis is licensed in this country for a particular stiffness called spasticity you get with MS, and a very rare form of epilepsy in children, mainly called Dravet syndrome. Cannabis is not licensed for any other conditions whatsoever. There are no proper trials of cannabis in CMT, and actually the trials, there's not really been good trials done in neuropathic pain. There has been some trials done in pain associated with cancer, so different kinds of pain. So clearly, you know, cannabis there's lots of different forms of cannabis. And yes, it is, I suspect it is effective for some forms of pain because it has been shown to do that, but it hasn't been done in a trial in CMT because CMT wouldn't be one that has usually a lot of neuropathic pain. So you will not be able to get it prescribed in this country. There are side effects from cannabis, but yes, like every other drug, it is something that would benefit from good trials of cannabis for neuropathic pain. And if it worked for neuropathic pain in other conditions, it might be something that could be trialed in CMT. But at the moment, it's not available nor being trialed for CMT, to my knowledge, for CMT.
Okay. The next question is about chemotherapy and the drugs used as part of cancer treatment, especially taxols and platins. Forgive my pronunciation of things. Can lead to early and permanent
exacerbation of the neuropathy.
Thank you. Exacerbation of neuropathy in CMT patients. What developments in oncology in general and chemotherapy in particular are taking place to address this negative outcome of cancer treatment for patients with CMT?
So I'm going to answer this in 3 ways. A very good question again, an excellent question. So first of all, so thinking of CMT rather than any other neuropathy, there is one example of a chemotherapy drug that absolutely makes one form of CMT worse. That is CMT1A, the common type of CMT, and the drug called vincristine. So that particular chemotherapy drug has a very high chance of making CMT1A worse. So by and large, we try to avoid it. So I would get a phone call maybe every 2 months from an oncologist, a cancer doctor, saying they have this situation. Now, clearly, there's a balance of risks here. Usually there's an alternative drug that can be used, but not, you know, if there isn't, you have to look at it. And the evidence really is mainly for CMT1A. There's not is strong evidence for it making other forms of CMT worse, although there's some. Now, with the other drugs, so the platins and the taxols that you've mentioned, those are chemotherapy drugs that very commonly cause a neuropathy in normal patients. So they very commonly cause a neuropathy. So those kind of drugs, if you give them to someone who has a neuropathy, be it due to CMT or due to diabetes or something else, they will feel worse because they have a cumulative effect. So most of those drugs don't exacerbate the CMT. It's an additive. They have a neuropathy on top of a neuropathy. And in that sense, it makes everything worse. So people again try to avoid them, but many times obviously they're brilliant drugs, Taxols and Platins. So what they try to do, you can't avoid them. So there's some very interesting research going on, and we've actually just got a grant recently, which we're starting, an international grant between here at Cambridge and Johns Hopkins in the States. And part of it is looking at this. It's to try to see, can we develop drugs that you give to someone before the chemotherapy to prevent the chemotherapy causing the neuropathy? So that it's just that it's difficult. One way of doing it is trying to develop new cancer drugs, and that's happening. But in the meantime, some of the cancer drugs are really good, and you don't want not to get them. So there's a move to try to develop drugs to protect the nerves, so that you give something to protect the nerve while you're given the chemotherapy drugs. And the way that's been explored is looking at the pathways that get worse when you give the chemotherapy drugs. So there's a lot of interesting work going on in that area at the moment, and some compounds in the preclinical level. So this is not in patients yet being looked at. So I think that is an important question. So I would say you could develop that question more, saying if you have CMT, I'd say to patients, it's like you really need an MOT every now and again. You don't want a second cause of neuropathy. So chemotherapy is one, but every time you go to your doctor of anything, you shouldn't take drugs unless you check, do they cause a neuropathy? And if they can potentially cause neuropathy, is there an alternative? Now, often there is, sometimes there isn't. Similarly, I strongly suggest people do not buy stuff off the internet, get stuff from, various herbs, remedies when they have CMT, because you really want to know what you're taking in. You don't want to be taking stuff that you don't know who made it, where it was made, are you sure it's right, and can it cause a neuropathy? Because some of the things you can buy can cause neuropathy, but it doesn't say it on the packet. I'm talking about, not drugs now, but I'm talking about additives and homemade remedies and various herbal remedies, etc., things that you can get that sometimes have stuff in them. So I saw a patient in clinic last week who had a list of things they were taking that included arsenic, and arsenic can cause neuropathy. It included lead, and lead can cause a neuropathy. So I think people have to be very careful that they try not to take things. Now, I don't want to make people frightened, because I don't know if any of you have ever been prescribed a drug and you take the list out of the box with a list of potential side effects, and it'll go on for 4 pages because every side effect that possibly can happen have to be mentioned. But usually these are really rare, and it's a balance of risks. So most patients can take drugs when they have CMT and it doesn't make it worse. But it's worth always checking, is it potentially causing neuropathy and is there an alternative? But it's always a balance of risks, and you should never not take a drug unless you've discussed it with your doctor if they've prescribed it.
Okay, thank you. I have a question here from a member who watched a documentary on stem cell treatment. To prepare the patient, they lowered their immune system using cancer-treating drugs. Would this work to slow down CMT, destroying the myelin sheath? Also, the cancer drug methotrexate, could this be a treatment for CMT as it slows down cell regeneration?
So I'll come at that a few different ways. It's a good question. We are asked it occasionally. So what you're describing there is patients that are going to have what's called an autologous stem cell transplant. So certain patients have bone marrow problems, or sometimes multiple sclerosis, for instance, is now one of the treatments for severe multiple sclerosis is a stem cell transplant. Now, those are conditions like multiple sclerosis that are due to abnormalities of the immune system. So the reason in multiple sclerosis, it's the myelin in your brain, not in your nerves, in the arms and legs, but in the nerves in the brain. The reason the myelin gets stripped off the nerves is due to the immune system attacking it. Now, CMT is not due to that. So what people like to do is reset the immune system. To do that, they take out somebody's bone marrow cells, and then they clean them up and put them back in again. And to do that, you have to give chemotherapy first to basically prepare the bone marrow for it. So autologous stem cell transplants and the use of these chemotherapy drugs are to clean the immune system up, reset it, so that people have an immune system that isn't attacking their own nerves. The CMT is a genetic condition. There is not an immune attack. So a stem cell transplant would not be suitable for CMT, nor would any of the drugs like chemotherapy drugs or methotrexate that are used for immune diseases be suitable. The other thing people ask about is other stem cells. Now, many of you may have heard of what's called iPS. So that's where it's called pluripotential stem cells. So what we now do in research is we take a skin biopsy from a patient, and many of my patients would have this done. We get cells called fibroblasts from the skin biopsy, and we can make those cells back into nerve cells, so tiny little nerve cells. Now, that's not at the stage of being able to use for therapies for patients, but it means in an individual patient, we can have their cells to try to find how to treat the disease. So one of the things we're doing now is we're actually working out how to treat patients by looking at cells grown from their skin. So that's a different kind of stem cell research. And in the future, that may have developments that we can use for therapy, but not at the moment. So autologous stem cell transplants are used in multiple sclerosis, but that is an immune condition that affects the myelin in the brain and spinal cord. CMT1A and other forms of CMT1 affect the myelin in the nerves in the arms and legs, not the brain, but it is not an immune attack. It's a genetic problem.
So very, very different.
Very different.
Indeed. Yeah. Okay. Do you know how many people in England are diagnosed with CMT, and of those, how many have type 2D?
So that's a good question. I can't give you an exact number offhand, but it's pretty rare. So 2D is a rare condition that mainly affects the hands first. It's a different form of CMT rather than the legs. There are 2D, even there's a few different genes that cause something that looks just like it, but I would say we only know about 20% of the genes for that. So 2D, if you actually look at the main one you see, if you look at I just pull it up here and I can't show it, but I'm assuming the person has a GARS mutation, that's GARS. I would have about 8 or 9 patients with a GARS mutation out of a couple of thousand. So it's very rare, and it will be rare. And around the world, most people have the same number of patients as I have. So I would say in the UK, there's definitely less than 100 patients with GARS, but I wouldn't have the exact number. I would guess it's less than 50. But there are other genes that are very similar to that mutation. It's not called CMT2D then, it's called a slightly different name, but it looks very similar. So it's a very rare form of CMT, yes. And it's unusual because it affects the hands first and worse than the legs.
Okay, and in terms of overall numbers of people with CMT, the estimate tends to be 25,000 for the
Yeah,
UK?
it's really interesting actually, because that estimate comes from 1973 in North Norway. Now, North Norway is great, but Norway has, a relatively, not quite inbred, but relatively inbred population, meaning there's probably more distant relatives than there are in other parts of the world. It's one of those areas. So people often wondered, was 1 in 2,500 an overestimate? But there's been many studies done, a very good study done from Newcastle that has, again, a pretty good fixed population. So people move in and out of Newcastle, but it's not got the same transitory stuff as London where people are gone in a year. Very difficult to do studies in London. And Newcastle found it was a little less common. So we tend to say it's between 1 in 2,500 and 1 in 10,000. And the reason we're a bit iffy about it is many people who will listen to this will know that they've had relatives who never saw a doctor. So, we don't quite know how common in the population is CMT that hasn't been diagnosed. Because when we see patients, it's not uncommon that we then diagnose a family that didn't know they have it. So I think we really don't know the true incidence, but it is no question about it. It is the commonest inherited neuromuscular disease. So myotonic dystrophy is pretty common, but this is the commonest. This is commoner than anything else. And we keep telling people it's important. So I tend to say 1 in 2,500 because it's useful to say it, but it's probably somewhere between that and 1 in 10,000. That's still pretty common. for a rare disease.
Indeed, yeah.
But the problem is most GP practices have about 2,000 patients. So your GP is either likely to have a whole family with CMT or never seen a patient with it in recent years. So it tends to be all or nothing with GPs. So that's why it can be frustrating for patients, because they may be the only patient in a GP practice with CMT.
Yeah, yeah, we find that with our members, and I will say at this point that if members would like us to send information to their GPs, just let us know and we'll do that.
That's been very helpful as well. I've had patients referred by GPs who the patients gave the CMTUK information to the GP, and that sparked the referral. So it has been very helpful when patients do that.
That's good to hear that it does work.
It does.
I have a question here from a member asking about any mechanism for sufferers to meet each other to discuss symptoms and strategies. CMT UK does have regional groups who meet. At the moment, quite a few of them are meeting on Zoom, and that's where people with CMT can get together and chat, perhaps have speakers. We're kind of exploring Zoom and how it's working at the moment, but there's a number of groups who meet and just to chat through anything they like, really, about CMT, about how it's affecting them, about how they cope, or just for a chinwag, really. So if you want to find out about those, do get in touch with the office and we can let you know when they're happening.
Can I ask you a question, Simon, about that?
Please.
Okay, so I think, I mean, it's been a really difficult time with COVID, and it continues to be extremely difficult. And I think CMT patients, it's been very hard as well, because a lot of people cannot get their routine appointments. But one of the things, there's always, something we learn from crises. And I think, I absolutely would not replace seeing patients by seeing them by video. I think seeing patients in person is really important. But I do think the power of the virtual environment like Zoom to have meetings is incredible. So I spoke recently on another disease, the TTR amyloid, to a conference for patients, and there was literally hundreds of patients from India, Brazil, etc., asking questions. So I'm interested whether next spring, if it comes through an AGM and your normal day that you have, I just wonder if you do have to do it virtually. My instinct is it might actually allow people around the country, many more people, accesses because of disabilities that mightn't have come. And I just wonder, moving forward, there might be that aspect always available with conferences, a bit like you're doing now. So I think it might be, when someone asks the question they've asked, I think this might open up a way of communicating more. And we certainly, as clinicians, are very happy to do things in this kind of a forum, because I think it helps people get access to us and us get access to more people to help them understand the disease.
It's certainly something, it's in many ways it's opened our eyes to the possibilities of doing things more remotely and reaching more people, those who can't travel or haven't got time to get to Coventry or wherever, from different parts of the UK. So certainly going forward, we don't know what things are going to be like next spring. I like the idea of having, if we're allowed to, having the conference live, if you like, but also finding some way of allowing people to watch it and in some way participate. I haven't worked it out how that might happen, but it's quite exciting. And as you say, it would reach more people and be more beneficial to people. So I'm certainly interested in what we might do.
Right, that's good to hear.
I'm hoping by that time we would have seen the back of COVID-19, at least to the extent we're seeing it at the moment, but and we can have a normal conference, but maybe with some enhanced.
Yeah. I think the other thing just to say is from, I have a very large practice of patients at CMT, and I think I want to reassure people about COVID. A number of our patients have had COVID, not many, but the same numbers you'd expect in the normal population, because many of our patients are young and working, and we haven't seen any more severe effects compared to the normal population. And that's similar to international practice, so in contact with people. So I think it doesn't seem that CMT makes you in any way more likely to either get COVID or have it more severe. The exception to that is the very rare patients that have a form of CMT where they might need help with their breathing, have artificial ventilation or, CPAP at night. Of course, that makes you people more susceptible to problems. But the general patient with CMT does not seem to be more at risk of either getting the disease or having it more severely. So I think that's we feel reassured by that for the moment, for the evidence we have.
That's really good to make that point and let people know that the risk is no greater as such. Question here about blue parking cards. I'm not sure. As a disabled person, why do I have to renew my blue parking card so frequently? We're not going to get better.
So I'm afraid that's something that's out of my control completely. I agree with you. It was ridiculous. I think you should get them for life once you get them, and or whatever. I think they make you do the driving, renew your driving license every 3 years. So it's not fair that you have the blue parking. I don't make these rules. They're very strict. And I think there's a lot of things that could be much better done. So I'm with you in this. And the nurses that work with us in practice spend a lot of time advocating for patients for blue parking and for all kinds of PIP and all kinds of things, because CMT is a rare disease in real life. So many people find they meet people that are making judgments and assessments on them that don't know the disease. And it's incredibly frustrating for patients.
And time wasting,
Totally
yeah.
agree.
There is a better way of doing it, and perhaps we should be
yes, and I think that's a very good thing, and that's something that crosses. It's not CMT. I mean, absolutely every genetic neuromuscular disease, you could say the same thing. Or that as to why this is, as you say, something that's not going to go away, and why do you have to go through it every time? It makes absolutely no sense.
No. Okay. The final question I've got is CRISPR, I'm not sure if that's how correct, it's pronounced. Yeah. Is CRISPR technology a possible solution for CMT? It's much in the news following the Nobel Prize.
Right. Well, I think it's a very good last question to be about Nobel Prize. That's somebody who's completely up to date. And yes, so basically it is already in trials, in preclinical, that means not in patients. So basically what's revolutionized the treatment of genetic diseases in the last few years is our ability to change genes. Now, I would never have thought when I started in CMT, I thought we developed treatments that were based on what the gene does wrong, not that we could go in and correct the gene. So now with therapies, they're called antisense therapies, silencing RNA, and now CRISPR. So CRISPR is a therapy, so you can go in and cut up a gene and patch it together correctly. Now that's a bit of an exaggeration, but it can correct a genetic defect. So CRISPR in some diseases has got to the stage where it's been looked at in patients. But at the moment, the main use of CRISPR is in the laboratory to generate models that we can actually work on. But there's no question already for CMT, there are some models of disease that are being treated with CRISPR, that is getting something into your body that can correct the genetic defect. One of the problems is making sure the CRISPR just, you've got 20,000 genes, half from your mom and half from your dad. And as well as those 20,000 genes, you have 98% of your genetic material isn't those genes, but it influences those genes. So you have to make sure that it's really precise. If you've put something that's going to go in and correct the gene, you don't want it to recognize any other part of your genome. So you have to make sure it's really targeted. And in CMT, it needs to get into the nerves, but not everywhere else. So that's what a lot of the work is going on, is how can you use technologies like CRISPR to go in and correct genetic defects, but do it in a very precise way with no long-term consequences. So it is very exciting, and if it matures into a treatment, which I think it will, then it'd be something you could do very early on in life to prevent the disease starting. Because at the moment, if you have CMT, once you've damaged the axons and you have muscle wasting and weakness, we can't reverse that with any therapy. So all of our attempts to have therapies are to prevent deterioration. So the other end of that is we develop therapies, we want to start them so early that you've got no problems. So as soon as a gene is diagnosed, you would then start the therapy. So in SMA, that very severe childhood disease, they're now moving towards wanting to screen babies at birth. So they start the treatment before there's any hint of a problem. And that may be in the future what we're doing for CMT. So I think CRISPR is incredibly exciting, and I think it was a well deserved Nobel Prize. And I think this will be one of, if people look back in decades to come, CRISPR will be one of those probably life-changing events when it matures into a treatment. So very exciting.
Gives us a lot of hope, really.
Absolutely.
New technologies. Well, thank you very much, Mary, for joining me today.
Not at all. It's a pleasure.
You shed light on a lot of the questions of CMT, and I'm sure there's lots more out there, but perhaps we'll do this again. Thank you very much. Thank you everyone for watching. I really hope you found it useful. We've received a lot of the questions from the CMT community, and we're sure there's more questions out there, and perhaps we can answer them again another time. If you would like some more information, please visit our website, cmt.org.uk, and we're currently running an appeal to plug our funding gap because of all the measures through COVID that caused a bit of a shortfall for us. So do visit our website and have a look for that. Feel free to share this video, this question time, and once again, many thanks, Mary, for your time.
Thank you.
Thank you.
Thank you.